Good morning, ladies and gentlemen, and thank you for the kind introduction, Chairman. I'd like to thank the organization for inviting me here to give this plenary talk this morning. And my brief is talk about surgical simulation, and the title is Innovation and Future Direction. There's a famous quote from a French surgeon, Ambrose Paré, and in fact probably is one of the fathers of surgery. And he already said, all improvements are illusionary and temporary if knowledge, experience, and skills cannot be or not transmitted to future generation of practitioners of the art and science of surgery. So the need to pass on our knowledge is essential in our skills. But of course, as you all know, for many years, again from the days of William Halsted, very famous American surgeon, who influenced really even up to nowadays, the way we do our training, which is the apprenticeship-based residency program. His model of surgical education has been faithfully and effectively trained countless generations of surgeons and successful in sustaining the art and science of surgery. But Halsted's apprenticeship-based residency program really has remained unchanged and unaltered from the day he started it in St. Johns Hopkins University in 1889. But there are a lot of limitations of apprenticeship training model that we have to address. Certainly, there are lack of important components to ensure the trainees are competent, including guidance, measurement of performance, feedback in a systematic and structural way. I was brought up today, the days when we were taught see one, do one, and teach one. So my total experience of operating on a new operation is 3 cases. And that would not be able to apply in these modern days of surgical practice. And not just that, it teaches limited exposure to skill, because nowadays we talk about a lot more about teamwork, communication, leadership, and management. And of course, there's lack of practice on a regular basis to do certain common operation, again, giving rise to likelihood of complications. There is a constellation of pressure on this apprenticeship program. Nowadays, a surgeon, we're in the first line of facing public scrutiny. Anything goes wrong with an operation, you'll be asked, is there competency involved? Because there are financial concerns. And now we face doctor work hours. Restricted work hours will limit our exposure to surgical experience. Of course, development of new technology and surgical technique, which I'll come to in a minute. And we need to develop more skill with less time of training. And how do we do that? As a surgeon, I've classified the recent major advances in surgical care have been the development of what I call minimal access surgery, of which 2 of which are in this example. Laparoscopic surgery, where we no longer have to open up somebody's abdomen to do complex surgery, reducing the trauma to the patient and increasing the ability to recover much, much quicker. And if most people don't realize, luminal surgery, endoscopic treatment using a flexible scope is also a minimal access surgery skill. Gone are the days when I have to open up a patient's abdomen to arrest a gastric intestinal bleeding like a peptic ulcer, because this is all done by an endoscope to arrest the bleeding with adrenaline injection. So again, a minimal access surgery skills. So my vision, or the vision of simulation, is to provide an inspiring environment to excel at creating, acquiring and sharing knowledge, experience, an innovative practice for our professionals in meeting challenges in today's healthcare arena. It comes into a new training paradigm for surgery, where simulation-based training is utmost important because it brings us theory to practice, knowledge to practice, and in learning by doing, we can experience mistake in the simulation, receiving correction from the proctor, and maybe start all over again in the program. We have been involved in training of minimal access surgery skill in our hospital for the last 18 years since the inception of the hospital in 1993. But of course, the new training center only come into being back in 2005. But previous to that, we do not have such a beautiful training center. And this particular floor is dedicated to surgical minimal access surgery skills training with a well-equipped live surgery demonstration, video conferencing auditorium. We actually have a simulated OR in the training facility to train teams of surgeons and nurses with the most modern, up-to-date laparoscopic and endoscopic equipment. Now, back to simulators. How do we use our simulators? Well, very early on, we have been using animal model as early as 1990s, when laparoscopic surgery came along in a way of doing cholecystectomy. That was the first available laparoscopic operation demonstrated worldwide, and surgeons in those days clamber onto the bandwagon doing this operation. We did have a lot of problem because it was not properly introduced. There was no simulation training. People were shown a videotape of how to do this operation, and then some surgeon went on and do it on a human patient. And we end up having a lot of complications with bowel duct injury. But of course, soon after that, enthusiastic surgeons, academic surgeons who were interested in promoting this work went into training courses to teach how to do a specific operation using an animal cadaver. Using an animal, not a cadaver. The animal was, the commonest animal used is the pig because it so resemble the human anatomy. And because there's legal and ethical tissue, the animal model are very expensive. But in those days, there are no other alternative but to use the anesthetized pig to do the operation. And this is how it was practiced. And you can see here this pig model of a gallbladder being simulated in resection. Of course, before you start on any side animal, a video trainer box is important because it allows you to actually feel the instrumentation and look at the monitor how you operate. And really, it provides inexpensive, efficient, reproducible environment for basic laparoscopic skills training. And this is what we do to start the trainee off by passing little beads from one end to the other end by using the instrumentation that was provided and looking at the camera, looking at the monitor to do the operation. We, in fact, have moved on in our center, and this is the training picture you've seen here, using the pulsatile organ perfusion. It really takes away the hassle of keeping live pigs, hiring veterinarian and team of anesthetists to do the work. This is a pulsatile organ perfusion model, a very unique design from Austria, by a surgeon actually, using the concept of the vipers in his Volkswagen car. And what he does is to harvest fresh organ, and in this particular case, usually pigs, and we cannulate the blood vessel. Using the motor, the blood vessel is being perfused with fluid that resemble blood. And the harvested organ is placed into this model covered with a material that resembles the abdomen. So the trainee surgeon actually introduced trocar to create the environment of pneumoperitoneum, which we need for laparoscopic surgery, and actually operate with the energy sources that he uses and practice on tissue that are being perfused. So this is more akin to the live pig situation, except that we don't have to deal with all the ethical issue of using animal experimentation. And we have been practicing with this model for various type of operation for many years already. Of course, those were the early days. Now the computer graphic is so mature that we are now able to use even more than just that type of simulation. Really, VR simulators are able to even model the full surgical procedure with anatomical accuracy and diversity with the virtual reality simulators. But it does come in a much higher cost. Each of the models are expensive. Of course, there are recurring costs for repeated use other than maintenance. And there are additional procedure simulation involve basic installing another program. So that's good in a way because the more program comes up, we just introduce into this model. And also you have the benefit of automation, whereby the training, instruction, and feedback can already program into the simulation. And the trainee who uses the simulator can get immediate feedback on the performance assessment without even the constant presence of a trained surgeon. I'll so show you some example of these models. And these are a virtual reality model teaching how to do a colonic resection with laparoscopic skills. This is a model for and next step of the simulation is but it really is a very, very effective simulation training. And the patient, the trainee really do get the tactile skills of doing the exact procedure or putting a stent in. So this is exactly what we do in the real life situation, but with this mechanical simulator. Of course, having done this simulation, we can then move on to real life situation. And this is a patient where the trainee is being taught under proctorship to achieve the same procedure